Well, good evening. Good evening to all of you, and thank you for joining Live Levine Update as we begin a new season of hearing from expertise across many professions whose specialties and talents respond to our questions during this most unusual phase of our lives. Most unusual, particularly for those of us enrolled in schools, teaching in schools, and leading schools. We're coming to you from Levine Academy in Dallas, and our audience tonight is our school's families, plus a number of friends of Levine across the country. I'm Tom Elieff, head of school here at Levine, and I've really enjoyed meeting with our special guests, and they've been fascinating and informative, and tonight will be no exception. A note to our audience, if you have any questions or topics you'd like our guests to address, please submit them through the Q&A down below on your Zoom screen, and we will get to as many of your questions as we can. Now, also tonight, you'll see as we move through the interview, a few survey questions will pop up on your screen. So we invite you to answer those questions. Those are questions for our school families. And there'll be about 3 or 4 of those questions. And just answer them. And once you click them, they'll blink off at the screen and you'll be able to see the guests. So I'm going to introduce fairly soon our first guest. But first, let's start with our Levine update here. We've been in school just over 4 weeks, and we've had 4 student cases, 3 of those in the early childhood division, with 1 in the lower school division. We've had 1 faculty member testing positive in the K-8, and thankfully in all cases, everyone has recovered nicely. Also, our faculty is in compliance 100% with our mandate, meaning all have been either vaccinated, about 98% now vaccinated, or in just a few cases, they are testing on a weekly basis. So they're following through on the mandate. Just a few data points that I want to share about our Dallas community. I know our guests will have more to say about this, but give our families some context about what's happening in Dallas. As far as what I see on the numbers, our 7-day average daily count is right at 1,200 cases here in Dallas. Now, I want to compare that with a few major cities in the country just to give you a perspective of what's going on. So you compare that to Chicago, which has under 1,000 cases per day right now. But Chicago has twice the population as Dallas, meaning Dallas has a higher per capita case count. Let's look at a comparison with Los Angeles. Los Angeles is at 1,800 cases per day on average. Yes, that's more than what we have in Dallas, but LA has 3 times the population of Dallas. Again, Dallas is much higher on a per capita case count. New York City, it's at about 1,500 cases per day on average. Yet New York City, has 6 times the population as Dallas, meaning Dallas again has a much larger per capita. Now, Dr. Evans, I know she can shed some light on why we're showing these numbers in Dallas in just a moment. We do a couple things about what we're doing here at school. We do send kids home if showing any symptoms of being sick. We have checks in place, testing as an option in order to keep siblings here at school. So we can test siblings, even if we send one child home. Oftentimes we would normally send all siblings home at the same time until the situation with that child is resolved, or with a physician's note or a COVID negative test. But we can certainly test children right here with your permission. Our K-8 Shabbats are only for classes at a time in Bait REA on Friday mornings. We keep the doors open outside. And just like we do that for the early childhood, when we have the Shabbat services for one section at a time there. So we're keeping things limited, and we're only thus far into these Shabbat services, allowing just one class or grade level of classes coming in at a time. And we're live streaming these K-8 occasions, and we're keeping our classes spread out from one another inside. And of course, we are all masked. Our interscholastic sports, they've resumed this year. We had to close them down last year, but we are practicing with masks, and we're also competing with masks on. So just to let you know, our volleyball teams, they're masked straight through all practices and during the actual competitions. Now, I want to thank my medical advisory team, and that's comprised of several Levine parents who are medical professionals, including pediatricians. They've been very, very helpful to us throughout this whole process. A few facility updates here. Here at Levine, we are looking into incorporating a new air filtration system into each of the classrooms. That'll be fantastic. There's new technology out there we want to take advantage of, and we'll give you details on that once we are able to acquire these. We're also in the process of designing and constructing a permanent outdoor classroom, and thanks to a generous gift from one of our families. So I look forward to seeing that when it's completed. It's going to be great as an option for all of our classes going on here. They can go out there and use it. And finally, I want to use this opening live Levine update to thank our many donors who supported our COVID fund last year, our COVID emergency fund. Our fund raised $300,000 last year just for COVID support. A project that was outside of our Levine fund, outside of our gala. We especially thank our leadership gifts from Ann and Nate Levine, who offered a substantial match gift. We want to thank Mark and Carol Creditor for their substantial leadership gift that really helped us with that big total that I mentioned to you. It did wonders, that COVID fund, for our ability to keep our school, our students, and our faculty safeguarded and equipped with what they needed to deliver instruction in the safest way possible. So I want to turn now and begin our show and bring our first special guest up. Now, let me introduce our first guest tonight. She is a member of the faculty at UT Southwestern Medical Center in Dallas, focusing on pediatric infectious disease. At UT Southwestern, she is the medical director at the infectious disease-related outpatient services. Her recent publications include topics on congenital syphilis, HIV infection in adolescents, and intrauterine transmission of COVID-19. She is also a member of a COVID-19 Public Health and Education Advisory Board for Dallas County. That's where I first ran into her, encountered her. And she is also the co-investigator on antiviral study for COVID-19 at Children's Medical Center, Dallas. So, I'm just so happy to have with us Dr. Amanda Evans. And Dr. Evans, welcome to Live Levine Update.
Thank you so much for having me.
Well, thanks for being here. And I just want to start by asking you to give us a little portrait of, I mentioned some things in Dallas, and I know you work for Dallas County. What's happening in this region with children and COVID in terms of case numbers and in terms of hospitalizations these days?
Well, to give you a picture, so I'm a staff physician at Children's, and last week I was on call for inpatient consultation services at Children's. I provided care for any patient that was admitted through hospitalization that required infectious disease consultation from the ED on the wards or in the ICU. And my pager was ringing continuously for mostly adolescents, but really ran the spectrum from newborn babies all the way up to adolescents that were coming into the emergency room and being admitted. Wow. in the dozens, really. And this was really at twice the peak of what we were seeing in the wintertime. And the infection rate, I think, really is stabilized for the adults, but for children, particularly adolescents, infection really is still climbing.
Oh, wow, that's right. Well, I mean, goodness. So Dr. Evans, I want to ask, before we get into some of the medical, questions about the virus and the potential for a vaccine for kids, of course, we're going to talk about. But can you share with us, with the audience tonight, a bit about UT Southwestern and its multi-front war, I would say, on this pandemic? I know there are, 250 investigative studies, and research projects going on, each year, and over $500 million in support to fund faculty research there. And I know it's an institution that trains, thousands, 3,000, nearly 4,000, medical professionals each year. And of course, on top of all that, it's a hospital with, I see these numbers like 360,000 emergency room cases, over 3 million outpatients per year. But of course, it's more than a hospital. Tell us what's going on there. Are we making any progress against this pandemic?
Our institution, I think, at the beginning of the epidemic, it ground our labs to a halt. But it also, I think, was a time where investigators of all stripes, malaria investigators, tuberculosis investigators, all turned their attention to this one pathogen, and used their technology to try to advance the science in this direction. Things that have come out in this pandemic, the sequencing, that we are now aware of the variants in our community. UT Southwestern really has been the driving force in identifying those sequencing in our area. And also there are some notable labs that are investigating small molecules and trying to investigate potential new therapies. Of course, those will be probably years in the development in the future, but hopeful strides.
Wow, it's really heartening to hear about the long-term research being done on those therapies. I think that, of course, we're in the phase of vaccines now, and that's the hysteria and all the attention. But if we can get to the therapies, that would be fantastic for this world. Our audience tonight, as you know, we're mostly parents of younger school children. And what can you tell them about the prospects for having a vaccine for children before winter break in mid-December?
I've been hearing a lot of mixed news. I think no one knows except for probably the investigators that are doing the vaccine trial themselves. But I think that the goalpost really is somewhere in the winter months. December, January, hopefully, is where we are hopeful to have vaccines in the arms of our younger children between 5 and 11. Of course, children that are experiencing severe hospitalization right now, that 12 to 17 age group, have ready access now for vaccine. And I would encourage all parents of children of that age group to go ahead and take advantage of vaccines now. Right now, only 40% of our adolescents in Dallas County are vaccinated. So I think we've got a large, area for growth in that area.
Well, a lot of, we're going to get to a lot of questions in our next guest regarding decision-making with the vaccine. But, I'm wondering right now, can you share with our audience, your level of confidence that the vaccine that will ultimately, be available for children will be safe?
I have to say that I've seen a lot of severe complications from COVID and from the multi-system inflammatory condition after COVID natural infection. I have yet to personally see complications from a vaccine, and we've administered over 100,000 doses of vaccine in children between ages of 12 to 17 here in Dallas County. That and the millions of doses across the US and globally, and the extensive record keeping, both by traditional record keeping measures and then also the data safety measures from the vaccine studies, gives me really good confidence in this vaccine.
That's great to hear. And, can you describe for us a little bit more about this variant, the difference between this particular Delta variant and the virus that we experienced a year ago? And, what are the characteristics of Delta that make it more contagious?
So starting off, we had what we are now terming the ancestral strain, the original COVID, which was a nasty bug to start out with. And as these new variants are coming out, just like flu that circulates and goes around the world and augments itself, we should expect the COVID virus to adapt to us and become fitter and stronger. This current one, Delta, it appears to have a little bit easier time because of those little rods on the exterior part of the virus to more easily transmit between people. There are now publications out documenting more cases by one person that is able to become infected.
Well, I want to ask a question regarding this, something I heard out there, and see what you say about it. I want to get your reaction. It's a situation I picked up from some of the medical sources, like the size or amount of the viral load, in an unvaccinated person compared with a vaccinated person. Now, what I've heard is that, if, let's say they're determined to be equal, but is that a relevant matter even? Because what I heard, and tell me if this is correct, that because for an unvaccinated person, the viral load faces little resistance, and whereas in the vaccinated person, the system, has a powerful response. What am I saying that right? Is that what's going on?
So there are some, scientific papers go through a peer review trial. There is some pre-peer reviewed paper that suggests that there's higher viral loads with the Delta in vaccinated people as compared to the old strain. I think that some of this data is yet to be confirmed with viral culture actually growing out live virus. There's anecdotal reports of breakthrough infection in vaccinated people in large amount. Baylor, our School of Medicine to the south in Houston, sent their first year medical school class, who was highly vaccinated, to orientation overnight with one, and a large percentage of their class came back with a COVID outbreak. So these kind of cluster outbreak events are happening in unmasked events. So I think that's why from the summer transitioning into this fall school season, we are now encouraging, because of Delta, even though we are vaccinated, we need to layer on protection, including masking.
Now I'm going to, relay just a couple quick questions from the parents. One is, if a child already had COVID, does that child still need to be vaccinated? That's one question. And the other one, looking ahead, will the children be needing to have a vaccine every single year, like they get the flu shot?
So even though people appear to have breakthrough infection, there is a small portion of those people with breakthrough infection that appear to be hospitalized. So the vaccines that people are receiving do appear to be doing their job in keeping people alive and then out of the hospital. That being said, the current recommendation is that if you have natural infection, that you should get vaccinated in order to protect yourself from severe infection and death. So it is recommended to get vaccinated.
Now, we're asking one of these questions we're going to ask the parents on the survey tonight, but I wanted to ask you, when the vaccine becomes available for children, would you be of the mindset to advise parents to hold off and wait a little bit and watch, see how it is taken, before they jump in with their own child? How would you advise them?
I can very much appreciate that it has been an expedient process. In my other hat, I am an HIV provider, and I've been, the HIV epidemic has been waiting 40 years for an effective HIV vaccine for those affected by that syndrome. But on the other hand, we have had the great fortune of having all of the scientific resources of the globe turned and investigating these vaccines. And these clinical trials are the greatest that we've had in number that the scientific community has had on record. So I personally have good faith in them, and I hope to have my children, my own personal children. I've got 2 in that age range that are waiting. My oldest already has been vaccinated, and I hope to have them. They will be first in line, I hope. So not literally, but I can't wait for the drop date for the vaccine, and I have no hesitation in getting them vaccinated.
That's great. And I know you got a kindergarten and 5th grader, is that right?
Yes, I do. Yes, I do.
That's wonderful. Wanted to ask, have you seen any, has UT Southwestern done any studies looking ahead at the numbers, at the current COVID case positive numbers in our area? And have they been able to predict when the curve is going to bend and things are going to come back? I mean, or it just seems that I don't know if we're flattening the curve yet. I mean, what kind of projections are you hearing about from among your colleagues?
So UT Southwestern, the bioinformatics division, has been doing wonderful work modeling how the COVID epidemic has been doing in our area, also in how it does in comparison to our related in our surrounding counties. Fortunately for Dallas County, in response to our current masking efforts, the overall case number appears to be flattening. It was appearing before the mask effort was in place that our case total was shooting up and was going to really like triple and quadruple compared to last winter. But it really has come down for the expected and anticipated total number. And there's a flattening of the curve according to those modeling numbers, which is really reassuring. I think the population that still has not seen that flattening is of the school children. And I think there's 2 reasons for that. Is they're a largely unvaccinated crowd. And also, I think we've got some work to do as far as masking in high dense populations.
Yes. So, this matter of you mentioned earlier regarding the numbers of children. I mean, talk about like maybe from 0 to 17. children, that are making up a larger bulk. Is that correct? That are being seen now in serious cases? Not to say that they are dominating in that age group, but can you just comment once again how you're seeing the trends in that age group vis-a-vis where we were a year ago with that age group?
So yes, in the winter, we had a little sprinkling of hospitalizations with severe disease. I think now it's really overwhelming our hospital system. And we're seeing a lot of adolescents, especially in the vaccinated age range. And there isn't a plethora of children that you would anticipate with large number of medical underlying illness. So these are pretty much otherwise healthy children, perhaps with a history of asthma or a couple of other incidental medical conditions. But largely their risk factor is being unvaccinated. And I think that's what is predisposing them to be coming into the ICU and requiring intensive care. So.
Yeah. Wow. Dr. Evans, it's fantastic work you're doing. Thank you so much for this portion of the show. And I hope you'll stay on, because I want to return with a question or two for you as we make a transition here and bring on our next guest. So Dr. Evans, thank you. And thank you for your work that you're doing on behalf of this fight against the pandemic. We're going to turn now to our next guest. She serves on the faculty at Johns Hopkins, Bloomberg School of Public Health. She's the director of behavioral research at the Institute for Vaccine Safety, an expert in vaccine behavior and decision-making, a behavioral scientist and a health communications scholar. Not only does she have a PhD from Johns Hopkins, but she also has degrees in political science and journalism and in international affairs. Professor Rupali Limaye, welcome to Live Levine Update, Professor. And I know you're coming from Washington, D.C. Thanks for staying up a little later tonight for us.
Yes, thank you so much for having me. It's great to be here.
Well, listen, describe for us the work you're doing in the area of, it's just fascinating, this area of vaccine decision-making. What does that encompass?
Absolutely. So previous to this work, working with vaccine, I primarily worked with vaccine hesitant parents pre-COVID. Since COVID has started, I've been working with vaccine hesitant individuals across the board. So that includes parents, that also includes adults. But before that, I worked primarily in HIV and AIDS and decision-making related to HIV and AIDS behaviors in sub-Saharan Africa. And so what we do is try to determine the ways in which individuals are making their decisions related to any sort of health behavior. So within the context of vaccines, we have seen, as I think Dr. Evans was mentioning, we have seen rates in coverage, vaccine coverage change over time, right? We're a little over 63%, I believe, of eligible individuals in the United States are fully vaccinated. Where I live, actually in the state of Virginia, we've done actually an excellent job, not only with those between the ages of 12 and 18, but then the adults as well. We're hitting almost in the 70s here in Virginia. But, we've seen some stark disparities related to that. I think Texas is a perfect example, as is Florida. We look at several states in the South, including Alabama, Georgia, Mississippi, Louisiana, all have very low coverage rates. And so what we try to do is identify factors that we can modify to really make sure people have evidence-based information to make an informed decision about whether or not the vaccine is right for them and their families.
Well, listen, I mean, I know this fantastic work you do there, and your colleagues are, there's just a tremendous number on this project. Can you share with our audience just a little bit about the big picture there at Johns Hopkins, in terms of research, data collection, and, the programs related to addressing the pandemic? Because I'm sure a lot of us, like when we look at the news, Johns Hopkins comes up so often when it comes to news and updates about COVID. And I wonder, what's happening over there?
Well, there's a lot happening. I'll start with some of our larger milestone projects. The first is related to the dashboard, which I think people might be familiar with. So that was actually developed here at the university with our applied physics laboratory, as well as our computer science and School of Public Health. And that really what that looked at was tracking of cases and hospitalizations across the United States. We've shifted that to a global focus. We've essentially looked at this in around 167 countries currently, looking at where there is increases in prevalence. And we're also tracking variants from a microbiology perspective. So I know Dr. Evans talked about the Delta variant, but we are closely tracking the Mu variant, which is the new emerging variant that's coming out. We don't know enough yet about infectivity and replication to determine whether or not the vaccines are going to be still effective, and hopefully they will be still effective. And then we have many of us that work on the trials themselves, right? So a number of investigators and colleagues of mine actually worked on the vaccine clinical trials. And so we've worked hand in hand with communities of color, with individuals that are experiencing disparities. And then of course, all the way to the side that I work on is really how do we make sure that we're communicating all of this effectively so that people have a clear sense of what is known, what is not known, and again, so that they can make an informed decision. So quite a bit going on over here. I'd say across my colleagues, most of us are working in COVID in some way, shape, or form.
Well, I'm going to have a question now that shows my naivete. And speaking to someone here who's an expert in decision making, and I know you teach a course, is that right, on persuasion right now?
That's right. I currently teach a course.
Sign up for that one.
Yeah.
So I was wondering, what are you learning about the reasons for resisting this vaccine? I was naive enough to think that at the outset of this pandemic that all it would take is to create a vaccine, and then we'll all just line up and everybody in the country will be done with this in no time.
Absolutely.
But I just thought it was going to happen in a matter of days, like the big huge stadiums with tens of thousands of people getting vaccinated, and we'd be done in a week. So there's my naivete. Now I'm turning into the expert here. Why am I wrong?
So
why was I wrong?
Yeah, no, it's okay. And let me explain to you, a lot of it, it's that idea, like if you build it, they will come. But we know from a health service perspective that we know that just because we have a service, i.e. a vaccine available, that we still have to create demand for that service. And so pre-COVID, we essentially saw 4 key reasons why people did not want to get a vaccine, right? So one was related to vaccine ingredients. The second was related to the vaccine schedule, how many doses children get between the ages of 0 all the way to 12. The third was related to risk perception. People felt as though a lot of parents would come to me and say, why does my child need the measles rubella vaccine? I've never even heard of rubella. And even if my child were to get rubella, I don't think it's severe enough that I need to warrant an action, i.e. getting a vaccine. And then the fourth issue that we heard was this misperception that there's a link between vaccines and autism. This has been soundly refuted in more than 600 studies, but we continue to hear this myth from parents. Now, how is that shifted during the COVID pandemic? In a couple of different ways. We still hear those reasons why, as to why people don't want the vaccine. But now I think the issues are much more, I would say, broader and at a structural level. We are hearing that individuals don't have confidence in the product itself, again, because it was an expedited process, even though there was no safety or efficacy corners cut through the development process. People have concerns about that. There's also a large distrust in the healthcare system that has risen over the last, I would say, several decades. 20 years ago, you might go to a doctor and a doctor would tell you to get a vaccine and 99% of people would do it. That has shifted considerably in this era of shared decision making. And the third piece that we're really dealing with that has been a huge struggle for those of us that are trying to mitigate this is polarization and misinformation. Again, 10 years ago, it would be much more likely that you would speak to people that might not have the same political beliefs that you do. Vaccine has become a very egocentric type of topic where people are very emotional about it. And so it's really hard to have discussions about it. And misinformation on social media, I think, is taking advantage of that polarization. And so we're seeing a lot of misinformation. And so I think the drivers have shifted a bit. We're still seeing some of the ones pre-COVID, but we've got some new reasons why people don't want to get the vaccine.
Well, from a school's leadership standpoint, I mean, I've been in schools for a long time, and like every school, we have our families submitting documentation of their children's vaccine, the vaccine record, the immunizations like diphtheria, tetanus, whooping cough, hepatitis B. I mean, you name it, hemophilus and pneumococcal, and I don't even know if I can pronounce all these, but the rubella, et cetera. Okay, well, maybe we've dealt with with the polio, but can you assure our parents that the eventual vaccine should be, no more cause for concern than what our families in America have had to do by requirement for decades now, and probably 99% of American families move forward with these vaccines with no questions. Or conspiracy theories. No one's advancing conspiracy theories about chickenpox, or rubella or mumps or whatever, and they turn them in all the time. And I don't know, no parents are writing to me a big issue about doing immunizations every year. So what's the deal with this vaccine now? And can you assure parents this is no big deal? It's just the next in the lineup.
Yeah, the way that I think about this is that I think about a vaccine as any other therapeutic product. So if you have high blood pressure, your doctor is going to prescribe a medication for you to make sure that high blood pressure is in check, right? A vaccine is like any other therapeutic product, meaning that there are benefits and there are risks to this. So what I like to say when I talk to parents is that the benefits heavily outweigh the risks in this specific context of COVID. And there's a couple of reasons why. One, I would say that even though this has gone through an EUA, which is the emergency use authorization, hopefully, fingers crossed, I just spoke to colleagues at Pfizer and Moderna in the last few weeks, and it looks like Pfizer will file for the EUA likely in the next several weeks, meaning kiddos between the ages of 5 to 12 will hopefully be able and have access to a vaccine by November or December, fingers crossed, as a mother who has 2 kids in this age category. But I think the first one is understanding that the development process of this therapeutic product, the only reason it was expedited is because we're in a pandemic. So the safety and the efficacy measures with regards to the independent safety review boards that are looking at these data is no different than any other therapeutic product. That's the first thing I would say. The second thing I would say is think about morbidity and mortality related to COVID. We know that COVID is has caused a huge issue with regards to morbidity and mortality here in the United States. We understand that it causes an excess amount of deaths and mortality almost in any other infectious agent that we currently are dealing with. And so if you put this in contextual terms, when people say, well, I'm not really quite sure, I don't know if I really want my child to get this vaccine. Again, I think about it as a seatbelt. You hope that you never have to use it, but you are happy that it's there. That's the way you should think about a vaccine as well. I think the third thing that I can say is that the actual formulation of the vaccine that will be given to children is exactly the same. The dosing is different. That's it. That is the only difference between what millions of Americans have now received. I think we're hitting 5.7 billion people worldwide that have gotten a vaccine. But the numbers in the US, I believe, are they're well over 200 million people now have gotten the vaccine. So the only difference between the vaccine that adults are currently receiving or have received is really just a dosing issue with your kids. So it's not a different ingredient. It's nothing else that's different. It's just a dose. And that's the way we do dosing across a number of antigens. Yeah. Wow. I think the third thing I would say is that if you are concerned, listen, you have every right to be concerned. It's a new product. We live in this very uncertain time. We're not sure. We want to do what's right to protect our children. But the way that we best protect our children is we immunize all adults around them until they can get immunized, right? Once they can get immunized, we continue to use these layered strategies, which I think you spoke about, thinking about masking, thinking about ventilation, still thinking about social distancing and doing contact tracing where we can. That is the best way that you reduce risk. So it's not just sort of an all or nothing, right? It's a combination of different things that will really help reduce risk to make sure that we are preventing severe COVID, which is exactly what the vaccine is designed to do, is prevent severe COVID, i.e. hospitalization and death.
Well, Dr. Professor Limaye, I got a few more questions for you, and so does our audience. I want to do this, if you don't mind. I want to bring Dr. Evans on because we're going to keep both of you on here because we're going to have a conversation, and I've got some fantastic questions coming through from the parents. And I'm going to try. I'll start with you, Dr. Evans, on this one. I keep hearing, and I'll read it straight from the parent. I keep hearing from people that the COVID vaccines in children can have potentially long-term negative consequences on fertility. Are these concerns supported by any scientific data or studies?
Sorry, needed to unmute myself. That's okay. And that's a great question. This has been looked at extensively, and there is no data in regards to any change in fertility. And it has been also looked at in pregnant women, and it has been found to be safe in pregnant women as well. Mm-hmm. So there is, and since we're talking about safety, there is there was a post-marketing, there was a flag that was raised in regards to males or boys between like 16 and 30 in regards to inflammation of the heart or myocarditis. So that was akin to some of the inflammation that is seen with natural infection of COVID, but in a very much milder form, very brief, if at all, hospitalizations, and has resolved for all of the vaccine recipients, I believe, that have been found to have this vaccine adverse side effect. So in comparison to the devastating consequences that has been seen to have myocarditis in association with either MISC or natural COVID infection, the myocarditis or the inflammation of the heart that is vaccine related was in peer review consideration, felt to be the risks of the vaccine were not substantial enough to avoid the vaccine for that age group.
Thank you. I'm gonna go back and forth here, Professor Limaye. I mean, a few questions. One is, do you do any work with like this whole idea of mask wearing? I know you do vaccine decisions, but masks and whether we should have them in schools and all that. I mean, a couple of questions here parents are asking are there studies that prove that masks in schools really work, and what are the cloth masks really helpful? And also a related question, are there any studies done on the long-term effects? Like, let's say, because here we require masks for age 2 and up in our school, and of course parents do express their concern, and I respect these questions regarding, is there a long-term impact on these kids wearing masks for 6 to 8 hours? I mean, what do you say about that?
Yeah, no, those are both really good questions. I think I'll start with the latter one first with regards to ill effects of wearing a mask for extended period. There have been several studies that have looked at this and have shown that there are negligible effects in terms of negative effects for kiddos wearing masks for that long. With that being said, it's very important for kiddos to have masks that fit them properly, right? That give them space to breathe. Some of the ones I know that parents like, they have a bit of that sort of beak, I don't know how else to explain it, that give them a little bit of space. Now, with regards to the type of mask that your child is wearing, your cloth is going to be, I think, the least protective, but it's still a mask. It's better than nothing. And you move towards an N95 mask, which is a surgical mask, it's going to be the most effective. But again, I think the most important thing is making sure that your child feels comfortable with what they're wearing. With regards to the first question of what we're finding related to masks, if you look at age groups, if you look at cohorts, i.e., kiddos between the ages of 2 to 5, then you go 5 to 12, 12 to 17 and up, and you're looking at prevalence of COVID, and you layer on top of that mask wearing, what we're essentially seeing is that masks are sort of negligible in the youngest age group, meaning they're going to provide the least amount of mitigating effects of COVID transmission. However, as we start to look up, we really do see that there was 2 studies that came out. I believe one was based out of the data that came out of Israel. One came out of, I believe it was the UK, that was just released earlier this week, that looked at this and actually found that, again, with layered mitigation strategies, masks plus ventilation, plus making sure that you're social distancing or podding, if you will, in schools, we have found that a combination of these different types of interventions will reduce risk of exposure. So again, I think from a school perspective, the more of these you can do, that's how much you're going to be able to decrease, I would say, your relative risk of exposure with regards to transmission.
Thank you. Thank you for that. Dr. Evans, I got a question here. There's a study, one parent is writing in that just came out showing that there is a 6 times higher rate of myocarditis going to the hospital than of going to the hospital with COVID in young children. Can you comment on the risks of the vaccine? I mean, I guess this is really about, what really percentage of the young children are the severe cases of the vaccine versus maybe severe cases of other, diseases?
And can you just restate that one more time? You said that 6% of,
Well, it said here that there's a six times higher rate, this person is saying, of myocarditis going to the hospital than of going to the hospital with COVID for the young children. I mean, I don't know if it's true. I'm just saying this is what is being posited here. You know, can you comment on the risk of the vaccine? You know, the thinking here, of course, is that a tinier percentage are going to the hospital or is really severe for children. Maybe you can comment on that.
At least in regards to myocarditis, in regards to the vaccine versus myocarditis with natural COVID infection. And this was analyzed by the CDC and the ACIP, the regulating bodies that look at the primary data that was gathered in it for vaccine recipients. The number of vaccine, the data really is the benefits are outweighing the risks. So it was a minority of patients, and they had short courses of inflammation and a minority of hospitalizations as compared to the great number of cases of hospitalizations and severe cases of hospitalizations due to myocarditis from natural infection.
Mm-hmm. Okay, I want to ask a question here. This is another one of these mask questions. Thank you, Dr. Evans, for that. I'm going to turn back to Professor Limaye on the mask, if you don't mind. You know, are kids better off inside wearing masks or outside on top of each other not wearing masks? we don't require masks outside. I'll just tell you how our school is operating this year. We require masks inside. So obviously there's a question about is outside really a protection for kids?
So, you know, what we have found essentially with regards to transmission in outdoor settings is essentially nil. I mean, it's essentially zero, unless what you're seeing, I think that happened in Chicago, where there was this huge concert and there were thousands upon thousands of people kind of all smashed into one space. That's not what we're going to get with kiddos when they're on the playground, for example, at recess. And so your chances of transmission, of, you know, any type of transmission happening outdoors is relatively zero to begin with. And so my recommendation would be, that is right. That's following the science, that you should not ask kiddos to mask outside, but they should mask inside. And again, that has to do with ventilation, to be quite honest with you. It really has to do with how air is circulating inside buildings. And in most school buildings, they don't really have newer sort of improved ventilation systems, but even opening a window or a door can do a lot with regards to the exchange of air that happens within any sort of enclosed classroom.
Mm-hmm. I want to follow up again with you, Professor Limaye, on this one question, and this actually it's a question for both of you, since you're certainly working on behalf of these immense organizations and institutions involved in this, but a very good question here, kind of a public service question here, actually, is could we be provided with links to studies that describe the efficacy of masks and as they are capable of reducing risk of transmission? It'd be nice to share with parents if you had a link to a study like that. And if you had such a thing, that would be fantastic. There is, and I'll follow up with you two with a few more questions coming up. And I know some of my parents here are posing particular questions about particular cases in our school. You know, I mentioned at the outset, but I want to, yeah, go ahead, please, Dr. Evans.
And if I could, I think that it's tremendous that we're discussing the school environment and you know, inside versus recess, but for parents also to remember the after school activities and the weekend activities that are so important to continue their good practices that they have during the school day, not to relax when they go to in-gym, you know, indoor gymnastics, or you know, these other potentially high-risk activities, that they would want to continue these best practices.
Thank you for that. I have a question going back to Professor Limaye. You know, are you seeing any, you know how these organizations are now coming out. Of course, Biden had this mask, this vaccine mandate. But are you seeing any change within organizations or companies where mandates have been issued and have these mandates changed minds?
It's a great question. And I'll say, so at the Johns Hopkins institutions, which includes our medical institutions, which is the campus that I'm situated at, as well as our Homewood campuses and our campuses around the world, we are required to be vaccinated. We're also required to be masked indoors. And that's because we want to reduce risk of exposure as much as we can. What we've seen from the mandate space, the federal government has mandated mask wearing use as well in any sort of federal building. A lot of this is a state by state, as you know, because of how federalism works in our country. The mandates come to the states. What's easier for the states with regards to really implement a mandate is that if it's a full approval, which is what we just had with the Pfizer vaccine, for example. So once we also get full approval, I think when we're thinking about for kiddos between the ages of 5 to 12, I would be not surprised if states follow suit and are making sure that there is a vaccine mandate. And that simply has to do with the fact that there's large populations that are indoors. The ventilation, as I mentioned, is not the best. We're not having a huge rate of turnover of air. And as a result, that's really the best way that we can really protect the health of the public. And for us, it's a tension, right? It's really balancing this idea of protecting individual liberty and autonomy, but protecting the health of the public. And so as a public health practitioner and professional, I think what we have seen with regards to mandates is that that's one of the ways that we're actually getting those that are still resistant, which is about 20% of the population that has not gotten a vaccine and is eligible. That is one way that we're able to actually get that proportion of the population vaccinated. And so again, I would argue the least restrictive means from an ethical perspective is important, but because of the negative effects of COVID and the strain on the hospitalization systems, it's really important for people, if they're going to be indoors, to be masked and vaccinated if they can.
No, thank you for that, Dr. Evans. I get a number of questions from colleagues and people around about the vaccine and its potential harm or for women who are, entering childbearing, who may be pregnant, who may want to, breastfeed after, of course, and as for the man and for the woman in this situation. And what can you say, or do we have studies about that? And should those in childbearing phases of life, be careful about the vaccine?
I think that now the bodies of the from ACOG, the obstetrician, and I can't remember exactly their acronym, but and the CDC, the FDA have come out with clinical trials endorsing vaccination with safety in pregnancy and also in breastfeeding mothers.
Okay.
This also protects infants because there is infant to mother transmission, and newborn babies can become very sick and ill and require hospitalization. There also has been shown to be miscarriage and stillborn deliveries from COVID, from pregnant mothers that get at COVID, and pregnant women have died also shortly after delivery of their newborn babies.
Very interesting. And Professor Limaye, for you, what about the social responsibility argument, such as, what about the argument that the virus exists only because there are unvaccinated people to keep this virus alive, and first of all, is that a fair, medical statement? And by emphasizing this, wouldn't we be appealing to the unvaccinated and their sense of commonweal?
What's interesting about this is that the whole reason all a virus wants to do is replicate. But to be able to do that, a virus needs a susceptible host, i.e. an unvaccinated individual. I think the finger pointing and the blaming has been a real challenge during this pandemic. I've worked closely with journalists. I've done about 300 media interviews now over these last 12 months to really talk about the ways in which we communicate this to the public. I do think that the blaming issue is causing, as I mentioned before, more polarization. What we have seen, though, is when we think about populations that have not yet been vaccinated and are eligible, we do know that there's a stark political divide, right? It's there. There's a political ideology that's driving a lot of these decisions. And so what I mean by that is that even if there are, individuals or colleagues that that have decided not to get vaccinated, the best thing we can do, in my opinion, is be empathetic, is that we need to figure out ways to which we can talk to one another, as I mentioned before. We need to be able to talk to neighbors and community members that don't think the same way that we do. And that's really the only way we're going to make it out of this pandemic. I do think that it has to be a more forward-looking vision from a community health and public health perspective. And as someone that studies health communication and decision-making, I think the finger pointing and the blaming is not going to help. So ways in which, and I know it can be really hard, and I'll put some posts also in the chat if people are interested, of how to talk to vaccine hesitant friends and family members without sort of losing your mind, because I think that's the question I get a lot, is how do you do it day in and day out? I think I've spoken to about 3,000 vaccine hesitant individuals over the last 18 months. And I think the key piece has to be empathy, is that we have to be empathetic. People are just trying to make sense of the virus and how they can mitigate really the sanctions, I would say, that the government is trying to put, on living their daily lives.
Well, I want to end with a question for Professor Limaye and come back to Dr. Evans for a final question too. I want to get to Professor Limaye on something you just mentioned here, about this issue of empathy, and and I'm wondering if to what extent is this dichotomy in the world a phenomenon that you feel is really pernicious and with us, such as where phenomenon today just seems more fantastical and extreme, these pandemics and climate change, and while the response, of course, is to listen to science, let's say, for those who are rational and really want to study this and who want to cope with reality and try to address the problems in the world. But there's a flip side of those who respond to these fantastical things like a pandemic, and they need to create a brand new fictional reality, in order to cope with this seemingly bizarre phenomenon. So can the scientific and rational and academic world make inroads into this alternative reality? And am I stating this dichotomy too simplistically? Is this an issue out there?
So, one thing that we call sort of our communication and how we've been dealing with individuals is this post-fact world, which is what we are living in and what you are referring to. I think it is not as simple as a dichotomy. I do think it's a continuum. And I think that part of the issue why it has become such a continuum is because we have lost faith in public institutions, right? That starts from the government, that then moves on down and trickles down to public health institutions, to scientists, to academics, to whoever have you. So I think, 20 years ago, a scientist would be able to come on and say, this is why I would recommend the vaccine, you need to get it, et cetera, and so forth. We're not seeing those same types of effects, I would say, that we would be able to see about 20 years ago. However, I am optimistic. I think that continuing to speak with people, continuing to talk to people that do not think the way that you do or have different attitudes and beliefs that you do is really critical for us to be able to thwart not only this pandemic, but future pandemics, right? We saw Marburg that just was popped up in West Africa again. That's another threat. Ebola will continue to pop up as we continue to encroach on land of animals. That's the reason why we're going to see more pandemics and outbreaks. And so part of it is going to have to be is that we need to adapt, that this is the new normal, that it isn't such we're a scientist and we're going to tell you why we're right and that's the end of story. No, it has to be more of a shared decision-making type of interaction and approach. And that includes at all different levels. So at the public health scientist level, but also at the provider level, at the community level, all the other different levels in which we can interact with folks.
Professor Limaye, I just want to thank you so much for being with us. It's been extraordinary, very, very informative. We're going to follow up with a few more, questions that have come up over the days, just to see if you can share some interesting links from your institution and to help us out here. We really appreciate you being on. Dr. Evans, I just have this question. Can you remark just on a long-term outlook globally, just your thoughts on this pandemic? Isn't it so that success for America, for America itself, necessitates success around the world? And how are we ever going to vaccinate more than 6 billion people with all these inequities in vaccine availability, not to mention the inequities in key information and the challenges we face in convincing people, such as what Professor Limaye has been presenting to us? The wild differences in what people believe and whatnot. And what's your outlook on this?
When I think about this from a 30,000 foot perspective, I think that Corona is not going away. I think that we are going to have to live with Corona likely for the rest of our lives. It's going to be a globally circulating virus that eventually we will have a portion of our population will have experience with natural infection. A large, hopefully part of our population will have developed immunity from vaccination. That vaccinated population will have develop a hybrid immunity from a series of vaccinations from the variants that come along, as we do for influenza. And it will tamper down from the severe infection that we have now down to a more seasonal minor respiratory infection, except for those that have a immunocompromising condition that have problems with establishing vaccine response.
I see.
Those probably we're going to have to adapt passive immunity and keep these monoclonal antibodies in stock for them. That's what I envision that's going to be coming for generations and for us in the future. So I think that we're going to, as a culture shift, going to have to adapt to and embrace the COVID vaccine, as we have with, 2 years ago, I took care of a patient with tetanus. It's routine for us to take care of patients with varicella and with measles in our hospital. Not often, but it does occur. So these vaccine preventable diseases are not extinct. So.
Wow, fascinating. I just want to tell my parents that so I want to thank them for the questions that came through, and also you had very good questions we didn't get to, but I do want to address them, not right now, but I'll follow up with the communication. Many of the questions I didn't get to were pertinent to specific cases here at school, and I'm happy to be full disclosure what we do, how we protect, what our policies are, our procedures, and I'm happy to go through that and let our parents know that we're there for you, our COVID team at school, with our medical advisory team, and still at work, doing everything we can to keep everybody safe. And with that, I just want to say again to Dr. Evans, thank you so much for being with us. It's so lovely to have you. And on behalf of Dallas County, I know, and you're working in support of all of our schools. Appreciate you very much being on Live Levine Update. Professor Limaye out there in Washington, D.C., thanks for staying up late and sharing your incredible expertise in this wonderful topic. It's a fascinating topic, and really my best to you, and good luck to you, Professor Limaye, and good luck to you, Dr. Evans, as you move forward to fight this pandemic. Thanks for doing what you do for all of us. And with that, I want to say goodnight to our audience out there. Thanks for joining us for Live Levine Update. We look forward to returning next month, and I'll give that program to you and a preview of that very, very soon. Thank you very much. Good night, everybody.